We start the program. Welcome on behalf of Independent Medical Practitioner Association. There are a lot of new faces today.
Chennai Metro.
I am a Chennai Metro Meditation. Now it's called Chennai Metro. It's a mini conference which we have every month. We take one subject like this. Then we took the common problems in your lifetime. We started pediatric, middle age, and old age. So we have 3 speakers. All the 3 of them will cover all the 3 in another 3 hours. We will finish off the entire thing. And after that, we have a small membership certificate presentation ceremony. The president will hand over the certificates to everybody. So I hope you're all comfortable. All of you have finished your lunch. All of you finished your lunch. Can you go ahead? Okay. Yeah, please keep your mobile in silent mode. Just because mic is yet to come, so it will be very noisy. Just keep it in silent mode.
I welcome all delegates and the speakers and also new members for the association. Wish them all best by their life.
Yeah, we'll start the first presentation. Dr. Priya, Madam, Dr. Subhash will introduce the speaker. And the first topic will be on pediatrics. All you common disorders in pediatrics and how to manage them. The entire topic will be like that. Half an hour to discuss the entire thing, the common problem. Then we'll have discussion for 15 minutes on that particular.
It's been a great pleasure to introduce Dr. Priya Biswakumar. He's a pediatrician and now he is director of India Child Care and district consultant at Apollo Children's Hospital and KK Child Trust Hospital. She has put up nearly more than 25 years of service as a pediatrician, and she got her MBBS degree from Madras Medical College and defended pediatrics from Premier Kanchi Kamakoti Child Trust Hospital. And she received her FRCP from Royal College of Physicians and Surgeons at Glasgow, UK, and also her post-graduation course from in pediatric nutrition from Boston University, USA. Her interest is mainly in pediatric infectious disease, vaccinology, pediatric nutrition, and adolescent medicine. And she has published a lot of papers in national as well as international journals. And she is also on the board of Asia Pacific Down Syndrome Federation and has done a tremendous work in transforming the lives of thousands of children with Down syndrome, including the research and the treatment. And she is also on the advisory board of prevention of crime and violence against women and children. She is very active in the social media and television, and she loves traveling, doing yoga, and she is also a serious mistake. Sorry, I'm not able to pronounce it. I invite Dr. Priya Biswakumar to deliver the lecture on medical management of common pediatric problems. Thank you.
Very good afternoon to Very good afternoon to all of you. It gives me a great pleasure to give this talk in a real world. So we have been doing a lot of webinars because of COVID. So though we are limping back to normalcy. I thank Dr. Kailash for this opportunity. I see many familiar faces. Dr. Kailash was my teacher in Madras Medical College, and some colleagues and good friends like Dr. Gerija. So thank you for this opportunity. I'm trying to do like a jugal bandi, so a little bit of many things that we see in our day-to-day practice.
So pediatrics, some of the words.
Yeah. Yeah, it was meant to be like that so that we are doing a post-lunch session. I thought, let's see if somebody spots it. So it was purposely put like that. So this is on pediatric problems. So before we go to problems, I think we should talk about general issues that we see in our day-to-day practice. I'm going to cover a bit on respiratory, GIT, genitourinary, CNS, and some miscellaneous conditions. So we know that now that there is always a interaction between for the developing brain and the body because of genetics, nutrients, and the environmental interaction. There's a lot of research now which is talking about the first 1,000 days of life. So right from conception to the first 2 years when everything is programmed. So after that, whatever we do, it is all building up on what is already existed. So we know that the most common thing that most of us in our OP, when parents come and see us about their children, is about in corridor or is always lean. Nobody says they are obese or anything, but whatever weight they are or height they are, nobody is happy. So what exactly is the correct thing? So we know that nutrition plays a very great role, and it's not just undernutrition but overnutrition also, as I think from the next few speakers we'll see is a major problem. So both these can cause altered organ growth and the genetic altered expression, which results in altered body function of every single organ, be it the muscle, where there is decrease in the muscle and bone, but there is increase in fat, there is decreased amount of nephrons, insulin secretion gets blunted, so there is resistance to the existing insulin, there is decreased secretion, decreased IQ and mental function, and increase in the fat mass. So all this leads to all the lifestyle disorders like blood pressure, diabetes, and obesity. Another common thing that we also come across in nutrition, which we see nowadays a lot, which I thought I would just mention, is cow milk protein allergy. So India is a country rich in milk. We have Amul dairy, we had the flood, Operation Flood and all that. But of late, we see many children who come with recurrent respiratory infections or a lot of atopic dermatitis or wheezing. So these children, when the protein part of the milk is cut down, the milk we know has a lactose and a alpha-lactalbumin and a lactoglobulin. So this protein tends to act as an antigen and causes a lot of problems, which results in recurrent respiratory infections. So when you have children who come with recurrent respiratory infections, you can do an IgE if it's an IgE mediated sensitivity, or try to remove it for a few days and see if there is any improvement in the incidence of recurrent respiratory infections. So when a parent comes and says there is a feeding problem, how do we actually approach that? So this is a kind of algorithm which shows how we can approach it. So first is go through a proper history and review the anthropometrics, the height, weight. Now, Indian Academy of Pediatrics has an app where you can put the growth chart and it will tell you where the centile is straight away. So based on that and a good physical examination, and then look for red flags. When a child is not eating, it's a very vague term. So actually if there is any dysphagia, there is any recurrent aspiration, there is pain while feeding. So when the child eats, sometimes there is a severe abdominal pain, or the child bends over, vomiting and persistent regurgitation. The child looks like it's got failure to thrive with low, stunted and undernutrition, or there is also associated developmental delay. These are all red flag signs which should tell that it's not just a normal problem, but there could be something more organic which we should not miss. So how do we approach this? We have looked at all the review of the history and anthropometrics. Then get additional details on the feeding practices. Is there a proactive feeding practice? Is the child being force fed? Or the parent wants the child to
Back.
So it's important to know the parent-feeding child interaction. So when you find all this, you can categorize the child into one of these. Whether the child has a highly selective intake, eats only plain rice with ghee, no vegetables, no nothing, everything should look white. Or there is a limited appetite. The normal child is perceived to have a limited appetite, or a vigorous child with little interest in feeding. Probably the mother just goes by the clock, says, okay, it's 2 hours now, let me just give something. So the child never has hunger. Or there is the child is depressed. Nowadays, a lot of this exposure to screens causes quite a decrease in the appetite. Or if there is any organic disease because of any of the red flags that we spoke. So based on whichever the problem is, we need to treat accordingly. Another common problem that we see is colic. Now we go to disorder in nutrition which leads to disease. The commonest thing in this season are all fevers. Fevers are, I think one can talk a full day on fevers because there is so much to talk. So what do we actually need to look? First we need to see the age of the child. If it is less than 1 month of age, then in a neonate, the fever can be more ominous and needs probably an admission and IV antibiotics and thorough investigation. Then look at the pattern of the fever. Is it continuous? Is it remittent? Is it a biphasic pattern like a dengue? Or is it just there in the evenings alone? So all this will give us a clue to the diagnosis. And the duration. Is it acute or more than a week? Then we look at enteric or more difficult conditions. And season. We are in the season, so whatever is we have a dengue outbreak as well. So seasonally we probably should keep an open mind to pick up because it can be very subtle signs. The most common causative agents are of course viral and bacterial. Viral, we have the influenza. We are having what is called a tridemic now. So there is an outbreak of COVID, influenza and respiratory syncytial virus happening now globally. I think the US and Canada are all overwhelmed. The health system itself is overwhelmed. We are also seeing a lot of viral infections.
But that's going to come to India.
We are having a lot of viral infections now. Yeah, it's a global thing. Yeah, we are having tridemic. It's not
more serious than the routine COVID.
COVID is a part of the tridemic. One of the viruses, the triviruses is COVID. We are not
obviously
testing.
The 3 viruses are attacking you means it will be more serious than the routine one.
Not the same person. You could have any of the viruses.
And the same vaccine is good for this also? No.
So the influenza virus depends on the NH season, where the northern hemisphere season. So those 4 strains which we regularly use could protect against the influenza type A viruses. We have influenza type A and type B. So usually every year there are sentinel places across the globe which do a surveillance of what is the circulating virus, and they make influenza vaccines twice a year. One is during March, April and one is during September. So this is called the northern hemisphere strains, and it has 2 of the type A and 2 of the type B. So to protect, even we ourselves should protect ourselves by taking the influenza vaccine, not just for our patients. So this could protect against this, and I'm sure all of us have taken the COVID booster. The RSV, respiratory syncytial virus, we have vaccines in the US, but we don't have in India. It can cause bronchiolitis and certain conditions and can be little severe sometimes. Bacterial infections, we have the spectrum. Of course, we'll come to that depending on the system that it affects. So, one thing with caution, all of us know we have to use paracetamol. But one of the commonest poisonings that occur is because of paracetamol. So, when you prescribe, I think it's important to mention because there are multiple formulations. You can have a Crocin 120, Crocin DS which is 240, you can have a Crocin drops. So, because the dosage that should be given for babies and children are 10 to 15 milligram per kg body weight, maybe 4 to 6 ali. Sometimes parents, take the drops and give the syrup dosage. So, it becomes like a poisoning. So, when there is something like that, if the total amount is more than 100 milligram per kg, we will have to use N-acetylcysteine to treat paracetamol poisoning. Ibuprofen is generally avoided during the season because it can decrease the platelet counts. So, though there is high fever, insist on just tepid sponging sponging is not just putting on the head like many parents think. It is just wiping the entire body, or put the child under the shower in room temperature water. Mefenamic acid in a dose of 10 mg per kg can be given every 6 hours. Some of us have had bad incidents with even ibuprofen or mefenamic acid in our practice. But generally I see fevers of 105, 106 which we've never seen happening during the season. And we also can use suppositories because it will instantly bring down the temperature. We generally avoid injections, but we use Fevastrin if it is very high and we need to definitely bring down the temperature. Another important thing why we do this is to prevent febrile fits. So up to 6 years, any child, when there is a rapid rise of temperature, even say 100 to 101, it is not the degree of temperature, but it's the rapid rise which causes the febrile convulsion. So this can be prevented by sponging the child down, and we use clobazam as a preventive thing for the first 3 days of fever. And of course adequate hydration and a good diet. So a word on dengue. I'm sure all of us are facing the onslaught because nearly every third or fourth child seems to have dengue with this particular type. So one thing is there are 4 serotypes in dengue. It's not just one virus. So some of them can evade detection. Also, if you're testing too early, you could miss the diagnosis. So there are four things. We call it probable dengue, then dengue fever with warning signs, and then dengue hemorrhagic fever with shock. These are the differences, a classification of dengue. So when we talk about probable dengue, probably the first 1 or 2 days where there is probably a rash, fever, high grade fever which is remittent with aches and pains. You could see leukopenia, but the first day you may miss it. Another thing is the warning signs. What are the warning signs? So this means that the child could get into a little more serious progression of dengue, which is abdominal pain, persistent vomiting, any mucosal bleeds, extreme lethargy or tiredness, hepatomegaly where the liver is enlarged more than 2 centimeters, or a hematocrit which is concurrent with a rapid decrease in platelet count. So what this virus does is makes holes in the blood vessels, so there is a fluid leak. So this is during the first febrile phase, which lasts about 3 to 4 days. Then you have the critical phase, which lasts another 3 to 4 days, and then you have the recovery phase. So it is important to give at least thickened fluids to the child to manage as an outpatient and monitor every day if you don't want to admit the child. It is better to give the fluids orally so that it doesn't accumulate in the as a pleural effusion and as ascites. When the child is recovering from the critical phase, when it's going into the recovery phase, there's a lot of diuresis. So to maintain a strict intake-output chart, so this will give a clear diagnosis. Monitoring to monitor as an outpatient. Another thing is repeated serial measurements of the complete blood cell count. So you see a leukopenia, and there are also decreases in the red blood cell and the platelet count. So we all think platelet. The most important thing is the hematocrit, which we should focus on. So we try to maintain a hematocrit of about 35 to 36, around that. So if there's a rapid increase in hematocrit, that means probably the intake is poor, or the urine output is poor, which may indicate admission for the child. And the platelet counts, we can wait even till 20,000. I've had children with even 7,000 platelet count. So don't just jump and give it, because there's an ongoing destruction. So in a smear you can see giant platelets which are present, which indicate ongoing destruction and formation of new platelets. So when to refer? So if there is poor intake, decreased output, the child is drowsy or having melena or any other bleeds, then we refer. So investigations, when you are doing the investigations, also do a liver function. So usually the SGOT and SGPT are also elevated. The first indicator is an NS1 which comes positive before the IgM. So if you have only an IgG and no NS1 IgM, it could indicate past infection and need not mean present infection. So we look at some of the respiratory conditions. I'm not going to touch on all malaria, enteric and things like that. I'm sure we all know those. So just some important points for some of the problems. So this is something that is very peculiar to children. So symptoms based on the site of involvement of the respiratory system. So as you know, in children there are adenoids, so decreased growth or snoring could indicate an enlarged adenoids. So when you do a lateral view of a neck x-ray, you can pick up this. Another common things are either a stridor which indicates an upper airway obstruction or a wheeze which could be a lower airway. So we look a bit into these. The stridor could indicate not just laryngotracheobronchitis, but it would mean laryngomalacia. Where smaller children, I had one child who came at about 20 days, was told by the pediatrician who saw, referred to an ENT who said there's a vascular ring and they wanted to do a laryngoscope and all, but it was nothing other than just a small laryngomalacia which didn't need any intervention, which would probably get better as the child grows. Hemangiomas can also present there, which can cause stridor. These can be present either because of an intrathoracic or an extrathoracic or an intrabronchial condition. The commonest thing for a wheeze we all know is asthma or hyperreactive airway disease. Other conditions could be foreign body or any compression from externally or even lymph nodes during there's any tuberculosis. So word on stridor. This was a 1-year-old male child which was rushed by his mother to the clinic. She gave a history of a sudden onset of a cough with noisy breathing. So you see this child, I can put the audio clip. I had somehow it didn't come through. So when we look at this child, the toxic child with high-grade fever and a kind of barking cough. So the cough itself gives you the diagnosis. Can have drooling of saliva if there are some associated aphthous ulcers, dysphagia or dyspnea, and restriction of neck movements. So when the restriction of neck movements, we think of an epiglottitis. The stridor could be due to, we said, various causes. And cyanosis or shock if it is getting more serious. So based on the site of infection, we can divide it into whether it's an inspiratory stridor, biphasic or an expiratory stridor. So when it is present during the inspiratory phase, the causes are epiglottitis group, which is a laryngotracheobronchitis, tracheitis, anaphylaxis. So in any anaphylaxis, that's what we are worried about. We are worried about a glottic edema. And it is biphasic when there is a glottic or subglottic and a cervical tracheal involvement. And an expiratory stridor when there is a foreign body or a bacterial tracheitis. So how do we manage this? So if it is because of a croup or a viral laryngotracheobronchitis, first thing to do is an adrenaline nebulization. So it's usually 0.5 ml per kg of 1 in 1000. The maximum is only 5 ml that you can use. So there's a dramatic improvement. Sometimes one dose of a dexamethasone can also help in decreasing the edema. If it is epiglottitis, then we have to use obviously ampicillin or third generation cephalosporins and associated steroids if needed. Retropharyngeal abscess is more life threatening. You can see in a lateral view, you can pick it up. And foreign body aspiration, you immediately have to do a Heimlich's maneuver to try and dislodge the body, and then bronchoscopy if needed. With children, it's you never know what you can expect. The word on pneumonias. So if the child now, we could have a child who we think may be wheezing, but actually could have a pneumonia, or it could be a bronchiolitis. So a pneumonia is a little more serious condition. Child may look a little sick with fever, with chills or rigors, maybe tachypneic. Not feeding. So there's a history first. When any child stops feeding, there's obviously something going wrong. So lethargy, malaise, and you can have wheeze or crepitations or auscultation. In very small children, it's usually a silent chest. So it's important to do an X-ray. The child is looking sick, always do an X-ray. You may find a patch. And look for the total count and differential count, CRP, and blood culture. So this shows the different types of pneumonia. It is very mild, just a cough, cold, no X-ray features of pneumonia. You give a bronchodilator, probably if it's viral, then symptomatic treatment. If it's bacterial, then amoxicillin in about 50 to 80 milligram per kg body weight. If it is the child is breathing very fast with a lot of chest indrawing, then amoxicillin should be given for 5 days along with a bronchodilator and adequate hydration. If the child is not able to take orally, then IV fluids and oxygen if the saturation is less than 90%. The child is severe, we classify it as severe pneumonia or very severe disease, then we need intensive care management and maybe ventilation other than the following things that we spoke about. So as I said, we need to differentiate between bronchiolitis, pneumonia and wheezing. Bronchiolitis involves the walls, whereas pneumonia involves the parenchyma and hyperreactive airway disease involves the tubes. So this is caused by viral infection. As I said, adenovirus or respiratory syncytial virus. They become narrow, so the child is typically coming with difficulty in breathing, tachypneic, irritable child. It's got only clear secretions, running nose, rhinorrhea with clear secretions and poor appetite. So for this kind of child, a chest X-ray will show a hyperinflated lungs. There will be no patch. So you can give IV fluids if the child is not able to suck well. This child needs admission and probably nebulization with saline or budesonide. There is no improvement, then we need ventilation. Then we come to asthma. I don't think we call it asthma nowadays, we call it hyperreactive airway disease. So this is a heterogeneous disease. I think I should not be talking in front of Dr. Kailash because I think he's like a authority on it. But anyway, with respiratory symptoms such as wheeze, shortness of breath, tachypnea, chest tightness, or just a cough, a child which is going on coughing, probably a nocturnal cough, always suspect a hyperreactive airway disease. Or even those who have a reflux can present as cough, it could be a hyperreactive airway disease. It varies over time. So how you differentiate it is, it responds to a bronchodilator and can recur again. Whereas if it's a pneumonia or something, it cannot improve with just a bronchodilator. So the points in favor are generally more than one type of respiratory symptom. So there can be a cough and wheezing, can occur variably. So more in the evenings or more in the nights or more in the early morning. Often worse at night or on waking because the histamine level goes up in the night. So this can cause. Also when the child is lying flat, there is a bit of reflux which worsens the wheezing. And typically exercise induced. So when the child is playing or not able to climb stairs or is running around and then coming back and just coughing. That's a typical exercise induced wheeze. They often appear or worsen with viral infections. They can aggravate it. So when there is only an isolated cough or there is a chronic production of sputum or chest pain or dizziness, it doesn't mean it's a hyperreactive airway disease. You have to look for other causes. So these are the triggers when we talk of hyperreactive airway disease. These are usually food or environmental triggers. So environment could be allergens, infections, microbes, tobacco smoke, pollutants, stress. And there could be if the parents are atopic or they have a family history of any respiratory illness can predispose the child. So there is a innate and adaptive immune development. And many children, we have the atopic march. So they present with atopic dermatitis. Then they develop all gastrointestinal symptoms, colic or dysbiosis, and then they go on to hyperreactive airway disease. So it's very important to preserve the skin barrier to prevent this march initially when we are treating this. So it causes persistent inflammation. Then there is remodeling and airway growth where you have to maintain them. So how do we classify this? The types of asthma are called transient non-atopic. So it's not triggered by any allergy, and persistent atopic. So non-atopic occurs in early preschool years. There's a recurrent cough of these, usually triggered by common respiratory infection. They say every week naanga vandundirukom ungala paakradhukku. So there is some viral thing which is kind of triggering it for the child. Improves as the child grows. Usually 70 to 80% outgrow by 7 to 8 years of age. And it can persist if it is atopy induced. So in the early preschool years, and if you see, there could be either an increased IgE and eosinophils. Sometimes it's in 2000s, 3000s. So you'll have to rule out worm infestation and other triggers which could cause high eosinophil levels.
Do you use biologicals for asthma? interact with us?
I have not used, sir. I don't know, not in children, sir. For atopic dermatitis we use, but not for asthma. We use now probiotics for asthma. They act by changing the gut bacteria, which helps in improving the symptoms. When there is an increased IgE, seems to help. Recently, there are some studies which have come out. Plantarium and all that. Lactobacillus plantarium, some certain types of probiotics seem to have come. Other than, of course, the bronchodilators and all that. So, when we talk about severity, it is whether it is intermittent or persistent. And when it is persistent, whether it's mild, moderate or severe. And when you are treating, well, it depends whether the child's condition is well controlled, not well controlled or poorly controlled. So how do we control? Before we go into the management, these are things which you differentiate. So usually in those with wheezing, there is always an allergic rhinitis, or it could be a chronic rhinitis or a sinusitis which is triggering the attacks. And there can be an associated adenoid or tonsillar hypertrophy. Sometimes nasal foreign bodies may mimic this. Middle respiratory infections could be pertussis, chronic bronchitis. These are differential diagnoses when you talk about wheezing. And lower infections, it could be even a reflux which is causing a cough, which need not be actually wheezing. So as I said, we use these severity scorings to see how bad it is for the child. One is the PRAN score and the other one is the CAS score, which I'll show you. So this is a pediatric respiratory assessment measure. So it's a validated scoring tool. It uses 6 things. One is the oxygen saturation, whether it's more than 95%, 92 to 94 or less than 92. Presence or absence of suprasternal retractions, scalene muscle retractions. How is the air entry, whether there is wheezing, and that gives the severity of the score. So if it is mild, it's 0 to 3, moderate is 4 to 7, and above that is severe. We use another score called the CAS score. This is a clinical asthma severity score. This is more when you assess the child. So depending on what is the respiratory rate, is it less than 30, 30 to 45, or 45 to 60, or more than 60, and what is the saturation being maintained by the child, and when do you hear the wheeze? Is it, there's no wheeze, is it a silent chest, or is there an end expiratory wheeze, or is it throughout expiration, or in both during inspiration and expiration? So this gives a stepwise increase in the severity. So based on this, we plan the management. So when there is mild to moderate exacerbation, we use salbutamol or any bronchodilator. Oxygen is the best bronchodilator. Even when we nebulize, always remember to do it with oxygen because it is more efficacious. And systemic or inhaled corticosteroids. So oral corticosteroids are for a short duration. They don't need tapering. It's just 3 to 5 days, usually 3 days, in 1 milligram per kg, probably of prednisolone or methylprednisolone. Once the wheezing comes down, we maintain on inhaled corticosteroids. Additional treatment that we use are ipratropium bromide. We use as a rescue therapy. So when a child is wheezing severely, we give a combination of salbutamol plus ipratropium, and we give it 20 minutes gap. Maybe 3 doses, 20 minutes gap till the child settles down, and then maintain them on salbutamol. Maybe ipratropium 6 hourly or 8 hourly for 2-3 days. We also side by side start the inhaled corticosteroids. This is to decrease the inflammation inside the bronchioles. So other therapies, oxygen can be given either by a nasal cannula or by a face mask if the child is a little more breathless. Systemic corticosteroids I already told you. And we use MDI or a metered dose inhaler, which is very efficacious. So 2 to 6 puffs, always give a spacer for a child. Don't use a direct thing, it's not very effective and the child cannot coordinate. So salbutamol nebulizer, as I said, every 20 minutes for the first hour, and then reassess severity and then plan your therapy. If more than 10 puffs are required, then you obviously need to admit the child. Then we come to some gastrointestinal and genitourinary conditions. So what மிச்சதெல்லாம் வெளியில வருது. So it is very important to know if it is just coming out like that or it's forcibly coming out. Vomiting is when there is forceful expulsion of contents by active contraction of the muscles. Whereas a reflux, it is kind of it just comes out without, it's like a passive expulsion, and the child doesn't look very sick. So this can be managed by propping up the child or giving some increased drugs which improve the motility. Constipation I will touch as we go on. And recurrent abdominal pain is also one of the commonest problems we see for school missing school. It can be due to multiple causes. Motion sickness is also, I think, a very difficult problem. So we use sometimes Dramamine or Evomin for that.
Do you use pantoprazole for reflux?
Yeah. We see a lot of reflux, and we use first ranitidine or H2 acid blockers like pantoprazole or lansoprazole. Lansoprazole. We have what is called junior Lansol. So it's 15 milligrams or 30 milligrams.
But that only reduces the acid. It's not going to act on the reflux.
No, because
lansoprazole only reduces acid.
Yeah.
It's got nothing to do with the
no, nothing to do with the sphincters. So that becomes better as the child grows. Or you give thickened feeds. If it is very severe, we give thickened milk feeds itself. Like we add rice formula to the milk to thicken the feeds. Or keep the child in a 45 degrees incline and monitor the growth.
Reflex, you diagnose in pediatrics by exclusion or no?
It is basically by history because we don't do any investigations as such. So it is generally immediately after feed. So typically the mother says they fed the baby, they put the baby on the shoulder and everything comes out. So the stomach is blessed. So then we keep the child, you have to sleep with
sphincter is
them.
not developed in the child, no?
We have a lot of preterms now. Many babies are born earlier, and then if there's atopy, reflux can get aggravated. Those children with atopic dermatitis.
Preterm babies, you keep by popping up like that or how do you manage?
Even term babies, we don't keep them up like that. We keep them in an incline,
Yeah.
like a rocker or bouncer we use, or 45 degrees angle. So, as I said, constipation is another major problem. It's a problem for the doctor, it's a problem for the patient, and it's a problem for the entire family. So, normal stool frequency is in Indian children less than 1 month of age, 3 to 4 times. This can vary even up to 15 times a day can be considered normal. So, it decreases like that. In older than 1 to 2 years, it's usually once a day. A delay, so it is defined as a delay or difficulty in defecation sufficient to cause significant distress to the patient. So even if the child is passing daily, but it's like a hard, like goat pellets, it is still constipation. If it's going once in 2 days and it's soft, it is not constipation.
Why is the infant passing 4 times a day?
Infant, because it's increased gastrocolic reflex when the babies are breastfed. So immediately when the milk goes in, they pass tubes.
Gastrocolic reflex is there for adults also.
But it's very pronounced in children, in infants especially. Neonates and infants very pronounced. As they get older, it decreases. So we, depending on the duration, we call it acute or chronic constipation. Now with a lot of Zomato, Swiggy and all has helped in increasing constipation now. There's a lot of junk food, there's no fiber in the diet. So usual causes, of course, organic causes could be first cramps, anorectal malformations. These we really don't see much in practice, but those are the organic causes. Certain drugs, any cough syrup can constipate. So if the child is wheezing or having some respiratory, the mother is going on giving cough syrups, that can again constipate. We always have to rule a hypothyroidism. Rule out a hypothyroidism. Certain other causes could be cystic fibrosis, which we also see. But the usual common causes are a low fiber diet, cow milk protein allergy, decreased water intake, no water intake at all. And the child is put in some school which is 1 hour away. So the child has to be bundled into the thing. There's no time for the child to actually pass motion. This is more in urban areas. So we see a huge incidence. The causes of constipation is usually functional constipation.
fetal protein allergy causes constipation?
It's like reflux. So they seem to cause either a reflux or vomiting or a colic or constipation. It's called a gut dysbiosis. By changing the bacteria that decreases propulsion. So these are the red flags which suggest a organic cause. So when the onset is before 1 month of age, when there is delayed passage of meconium, more than 48 hours after birth, then there is an abdominal distension, failure to thrive, or presence of a pilonidal dimple, tight anal sphincter, etc. And this is very common in adolescence. So adolescence comes with soiling. It's very common in adolescence. And it's also very difficult to treat. This is called a Bristol stool chart. So some of us use this in our OP. This sort of gives the parent an idea on how to explain. So this shows what is a normal stool, what is diarrhea, and what is constipation. Otherwise, everyone likes to take photographs and come and show it now. We use what is called the Rome-4 criteria. The Rome-4 criteria we have for colic, for constipation, for recurrent abdominal pain. All these, there was a conference in Rome which gave some criteria. So in this they said it must include 2 or more of the following occurring at least once per week for a minimum of 1 month to classify it as constipation. So 2 or fewer defecations in the toilet per week in a child of at least 4 years of age. At least 1 episode of fecal incontinence per week. Posturing. So the child typically goes and stands in one corner, scissors the leg and stands. Because it's holding the anal sphincter so tight to prevent the stool coming out. Because every time the child passes, he or she is having severe pain. So the pain is uppermost in the mind, so they don't want to pass. And sometimes presence of a large fecal mass in the rectum and history of large diameter stools that can obstruct the toilet. So what is new in this? The duration of symptoms. This can be present even for 1 month to classify it as constipation. So in the absence of red flags, what we do is proper toilet training in a very in a manner that is not very troublesome to the child, and we use what is called PEG. PEG is polyethylene glycol. We used to use lactulose and many other things earlier. Now this is the more recent thing which we use, called PEG 3350. This is can be used for up to 3 months. No, it's a liquid. So smaller quantity and it's easier to give. So from constipation we go to the other end of the spectrum, which is gastroenteritis. So of course we have a history of vomiting or diarrhea associated with fever. Now with the rains, history of consumption of contaminated water. Always check for the urine output and the sensorium of the child. And the child may be very eager to drink, which is suggestive of impending dehydration. So don't force feed, give a gap and feed. So I had one mother who came 4 or 5 times vomiting, I had to give an injection, and then she says, "Oru idli na saaptadu." Another one said, "10 idli na saaptadu." So it's very relative. They really don't know how much to stop. A child's stomach is the size of its fist, of the child's fist. They can't go on. No, one mother came and said, "10 idli na saaptadu." No, enna kudukarga. So don't force feed and avoid allergens or triggers. So usually citrus fruits act as irritant. So try to use apple or something which has scaline and pectin which can bind. And antiemetics should be used at discretion. We don't use anti-motility drugs like loperamide and all in children.
Antiemetic is
Domperidone.
not in
Both, sir.
Ondansetron also.
Only 2 things we use. Sorry, ma'am.
There is less than 7 years. What is the name? Ondansetron?
We can use it's quite safe. So red flags are multiple episodes of vomiting. So obviously the child is getting dehydrated. And if the oral antiemetics are not working, then we also use a strip. It's called Emifilm, one of the brands. We just use as like a paper and it dissolves. So this will prevent the child getting admitted. And look for any altered sensorium and associated fever. So these are the plans for homemade ORS. The simplest thing is in a tumbler of water, add 1 teaspoon of sugar and a pinch of salt. If the child finds it difficult. brands. For example, at this quote, we have one thing called ORSL. So everybody knows it. It's basically just a drink. It's not an electrolyte. So only when it says rehydrate is it an electrolyte drink. Otherwise, it's like Real or Tropicana. So when you're prescribing, make sure that the right electrolyte.
Rehydrate is the low sugar
Low
part of it.
osmolar.
Low sugar part of it.
Yeah.
The one with taurine is not also there. That is the
Olite.
Warfel L.
Yeah.
Pedialyte.
So some of the other interesting things that we see are we never know what a child can swallow. It could be a coin, it could be a battery. So when we are faced with something like this, during this age group, 6 months to they're exploring their environment. So the child could be coughing, drooling, and gagging. So when we take an X-ray, this is what we see. If it's a homogeneous opacity, it could be a coin. And if there is a double ring or a halo, it is usually a battery. So these batteries are more dangerous because they can they have acid in it, which can cause very serious consequences. So button batteries, which are there in many of the toys that we use, large and esophagus needs immediate removal. So an endoscopic removal may be required. Large objects, so there are two portions. One is near the duodenum, that's a narrower portion, and second is near the appendix. So if it clears these, then the object will come out. So magnets are again can cause more serious thing because they don't come out. Lead-based objects can lead to lead absorption and poisoning. And certain toys can just break into multiple components, which can cause more serious problems and difficult to monitor. So when there is a child with a suspected foreign body, see if it is a high risk object or something which is not very bad, like a small rubber, crayons or clay. All these are not very bad things to swallow. So then see if it is radio opaque or radio lucent. Only certain objects are radio opaque. See where it is. You may have to do multiple things to monitor and bring it out. Do not induce emesis. And if it is still in a particular position and it's not able to come out, or if it's high risk like button batteries, large objects, sharp objects or toxic objects, it has to be removed by endoscopy. So another common thing for school refusal and what parents bring for us is acute abdominal pain. Now abdominal pain is a very vague term, can be due to 1,000 causes. So usually in very young, in infants and neonates, it can be due to a colic, which we still do not know the cause. So certain, we have anti-colic medications which we use. Probably the child cries at the same time for 2-3 hours every evening. We use certain things like that, or decrease the milk in the mother's diet if the child has got cow milk protein. That also helps decrease the colic quite significantly. We also have certain probiotics which help like Lactobacillus reuteri, which is helpful in decreasing colic. Acute gastritis. I don't think we would have spoken about gastritis say 10 years back in children, but we see plenty of them because they eat at very wrong times, they eat the wrong kind of food, very easily available, they're given money, Lays packet, all kinds of things. So there's a lot of gastritis. Because we use H2 blockers like ranitidine at 2 mg per kg, can be given for a maximum of 3 months, and lifestyle modification or omeprazole. We don't use omeprazole, lansoprazole or pantoprazole. Constipation we spoke about. Appendicitis, if there's a lot of vomiting, diarrhea and a sick child, then you will always have to do an ultrasound with abdominal pain. It need not be only in the right iliac fossa. If it is retrocecal appendix, it can be, even in the epigastric region. So ultrasound may help.
At what level will you, referring to a surgeon?
So if the child is looking, there's kind of tenderness, like a rebound tenderness, then I would definitely get a surgical opinion. Ultrasound does not pick up initially. So you may need to do a CT scan, which may pick up, but we can't be doing CT scans for everybody. Yeah, so a surgical opinion definitely, and keep them on just clear liquids and see and get a counts and a CRP. So that will give us an indication of whether it's appendicitis. Intussusception is again.
We do also see worm colic.
Yeah, worm colic is also very common. Some vague abdominal pain, we'll have to rule out a worm
routinely dehome children?
Yes, so school going children, yes, once in 6 months. And your minimum gap is 3 months if they are symptomatic. Albendazole. Or mebendazole if they are resistant. And we use ivermectin in combination with albendazole if it is very resistant. And you always have to deworm the entire family. And it's always 2 doses 2 weeks apart. Because the medicine works only against the worms. It doesn't work against the eggs. So we give again after 2 weeks. Intussusception is another life-threatening thing which we need to pick up early. Ultrasound will clearly show claw sign. It can be reduced by saline infusion. So a bit on seizures, CNS conditions. Most common is of course febrile seizures. Main thing is to make sure you also do an EEG after 1 month to make sure it's only febrile seizures and not any other cause. Infections, status epilepticus, I'm sure we all know. We manage initially febrile seizures with fever prophylaxis and clobazam. Other things, I think we use midazolam initially and whatever is appropriate anti-epileptic medication. Head injury. So any injury to the head is called a head injury. It doesn't mean the child has to fall from the first floor. The child could even hit against table hard and have a serious problem. So look for any signs of drowsiness, vomiting, projectile vomiting, any bleeding from the ear, nose or throat, or any convulsions. So it doesn't mean all this will happen within the 24 or 48 hours. It can happen later also. So always go by what the parents are saying. So if you think, oh, why should we make them spend? If the mother says, always take that. There will always be something to it. So better to get a CT scan. X-rays are not very clear in showing delineation. We are basically looking for any subdural hematoma or any other hematoma which is pressing somewhere. The signs to look out for are any even bradycardia or alteration in the pupil size. All this can give pupils. So we don't send home if they have any of the 4 symptoms that I spoke about. So other common causes for, another common thing which we see is headache. So headache, common thing which is missed are refractive errors. This is one of the things, sometimes children have -3, -4, it's been totally missed because the other eye is compensating. So always make sure you get a vision check done. Another thing we also see nowadays, I think because of the environmental pollution, is a lot of sinusitis. If you don't have a diagnosis, if you ask them to take a PNS X-ray, you will definitely see a sinusitis. So that leads on to a lot of wheezing as well. Migraines in children can be like a classic migraine with severe headache, with vomiting. Can also present as abdominal pain. Sometimes just recurrent abdominal pain can be migraines. Meningitis, I'm sure we all know that there's neck stiffness associated, then we look for that. A few miscellaneous conditions that we have to know. One is, in the West, and many people said that they're going to the US to attend on their daughter and all that. The commonest thing that happens in emergency anywhere abroad are allergies. Like we have infections. That is the commonest admission. So here we are seeing an increase. We are in the, caught halfway. We also have a lot of infections, we also have a lot of allergies. So food and environmental. One of the interesting things that I saw on these allergies, that ant there, that's called a fire ant. So that ant can cause life-threatening allergy in 15 minutes. We've never heard of something like this, but I've had 2-3 children like that. They have to reach the emergency and have adrenaline, and because they can just collapse. So that is one thing. Atopy is on the rise because I think the gut bacteria is changing with improved sanitation. Drug-induced allergies, any drug can induce. Sometimes even Montelukast or things which we use to control allergies can cause allergies. And topical application of any agents, creams, and of course insect bites. So the symptoms can be involving the eyes, conjunctival congestion, rhinorrhea, or rashes everywhere. So the immediate care is first remove the allergen from the site, use appropriate antihistamines, and eliminating allergens from the diet. If it is because of say prawns or seafood, can cause. And those who are having this kind of severe allergies, we recommend them to keep what is called an EpiPen, which is available abroad, which is like an adrenaline. It's like a pen, like your insulin syringe, which you can inject to manage the thing, and eliminating any environmental allergens, dust, mites, etc. So the red flags are if the child has extensive rashes over the entire body, difficulty in breathing, swelling of the entire face, and is a very small child, may need admission. These are red flags. So another thing is when we tell children to do steam inhalation, or even when the mother is cooking in the kitchen, this can happen. Scalds and because of hot tea or water falling on the child, and it's also common during bathing. So never leave children unattended when there are hot objects nearby. So immediate care is to assess the burn area. We use this kind of chart and wash the area immediately with cold water, and if there are blisters, never puncture the blisters. They are important for healing. We have certain agents, I think like Silverex SSD and Mega Heal, things like that, which can be applied over the area. And adequate hydration should be given. If more than 10% of area is involved, or if the age is less than 10 years, or very sensitive areas like hands, feet, or genitalia are involved, it can be a little more severe. And colloidal dressings may be necessary. Important thing to do is pain management in that case. So the commonest things in any burns or scald injuries is infection and pain. So these two things should be looked into. So poisons are not something like only organophosphorus compounds or something. Poisons are common agents that we use in our day-to-day practice, like Lysol or any cleaning agent, or anything can be a poison. So make sure it is all locked and kept. Another common thing, like I said, paracetamol poisoning. Iron is very common, which comes as poisoning for many children. And even I had one autistic boy who took an Odomos and put it and brushed. So you can never predict what can happen. So the red flags are if the child is abnormally breathing, or there's an altered sensorium, and could have even swallowed any of the grandparents' tablets, which could be diabetics or leading to hypoglycemia, can manifest as seizures, hypothermia. So this is something that I spoke about earlier regarding skin conditions. Atopic dermatitis, it's a chronic inflammatory, relapsing or recurrent kind of condition, which we see quite high nowadays in infancy. Nearly 17% of children. It occurs more on the flexor aspects between 2 to 3 months of age. Nearly 50% of infants will develop by 1 year, and quite a few of them before 5 years of age. So in this, the triggers could be direct contact and food allergens. So the 5-6 main allergens are tree nuts, peanuts, cow's milk, soya milk, and seafood, and sometimes egg. So these are the common triggers, in addition to stress and contact things. So treatment could be use of emollients or topical corticosteroids and calcineurin inhibitors. So these we classify into mild, moderate, and severe, and maintain them on good moisturizers and emollients, and treat flare-ups with steroids. They can have urticaria, which can manifest like this. So another thing is bites and stings. Now there have been some shifts in recommendation in bites. During the pandemic, I think many people started having pets. So a lot of increase in dog bites and abnormal behavior by pets also, because they've kind of been restrained. So any injury where there is a break in the skin needs anti-rabies. If it is immunized dog, non-immunized dog, doesn't matter. You have to give anti-rabies. Minimum is 4 doses or 5 doses. And if it's a pre-exposure prophylaxis, it's 3 doses according to the schedule. And the site should be infiltrated with rabies immunoglobulin. So you assess the wound site, clean it, wash it well. Tetanus should not be given every time. So we have a schedule. So if it has been given at 4 years and the child is 8 years, does not need a tetanus, only to be given at 10 years. It can cause sensitization and serum sickness. So these are first aid.
Rabies is real.
Sorry?
Rabies immunoglobulin only it is on the face or
No, anywhere. If it's a grade 3 wound, then we have to infiltrate.
But rabies vaccine per se, every year you have to repeat.
No. If you have finished the entire course, it works for 3 years. give only a booster dose.
One dose.
Yeah. So I think I've rushed through a lot of things. I hope it was useful. Thank you for your
We had a very good she's trying to cover the ocean in 45 minutes. It's such a vast subject. It's very difficult to cover. But anyhow, she has tried and learned best. As a token of appreciation,